speaker, Dr. Daniel Blazer. Dr. Blazer is a J.P. Gibbons Professor Emeritus in the Department of Psychiatry and Behavioral Sciences and Professor in Community and Family Medicine at Duke University. Dr. Blazer received his MD degree from the University of Tennessee and his MPH and PhD degrees from the University of North Carolina at Chapel Hill. He is a geriatric psychiatrist and epidemiologist with clinical interests in geriatric psychiatry, mood and anxiety disorders, psychiatry, and religion. Dr. Blazer spent many years leading major community-based epidemiologic studies and later transitioned primarily to collaborative secondary data analysis in the areas of late-life depression and substance use disorders, psychosocial predictors of adverse health outcomes, and trajectories of health outcomes. He's worked on several important research collaborative projects, including the Established Populations for Epidemiologic Study of the Elderly study and the National Comorbidity Study. As part of this research endeavor, Dr. Blazer led investigators who demonstrated that the prevalence of major depression is higher than previously estimated in national samples of persons between the ages of 18 and 55 in the community and discussed the methodological issues that may contribute to this differing estimate. Dr. Blazer has been honored with many distinguished awards of research, teaching, and psychiatry, including the Distinguished Alumni Award at the University of North Carolina School of Public Health, First Annual Geriatric Psychiatry Award from the American College of Psychiatrists, the Distinguished Faculty Award from Duke Medical School, and the Kleemeyer Award from the Gerontological Society of America. He was elected to the Institute of Medicine National Academy of Sciences in 1995, where he chaired the Committee on Cognitive Aging, and he received the Walsh McDermott Award for Outstanding Lifetime Service to the IOM in 2014. He currently also serves on the editorial board of JAMA Psychiatry. Please join me in welcoming Dr. Blazer.
It's always good to be back at UNC. I think of all the educational experiences I had, and even being a Dukey, I have to say this, the best one I ever had was the time that I had here at UNC. With some wonderful teachers and a colleague, Vic Schoenbeck, and I were students. I will tell you one thing about Vic, and that is he was the star of the class. The rest of us were just trying to hang in there. But he was the one who was actually leading everything along. So he was an inspiration to me and to many other individuals. Another thing is, if you'll notice from the introduction, I have virtually no background in cognitive aging. And so I chaired this particular committee, and this is sort of a unique characteristic of the Institute of Medicine. They want somebody to chair a committee who is not biased. And the best way to find somebody who's not biased is to find someone who doesn't know a lot about the topic. And now I'm actually chairing a new committee currently, which is on hearing impairment, and I totally don't know about that. So again, I'm unbiased. But this was a committee and an activity that I'm very excited about. It's received a lot of attention. And so I'm going to work you through just sort of the, maybe not the 10,000, but the 5,000 foot view of sort of what we came up with in terms of cognitive aging. See, I probably can do this. I can probably do it like this. Let's see if I can. No problem. Do it a minute ago.
It was. Let's just exit out and then try again. This is not working either.
Is there a keyboard there?
Yes, but it's not working.
Is it turned on? The keyboard has a switch on it, a little switch in the top right. Should
It is
show
on.
green.
Yeah. This is odd. I can't even exit.
The expert here.
Meanwhile, I can say that you've already blown your credibility by saying those things about me.
Okay.
Obviously, it wouldn't be working. Okay, let's see. Okay.
This is just a part of the seminar.
Okay.
It's a way of introducing
understand.
speakers.
So you know that computers can have cognitive aging also?
Is it this one?
Yeah.
Okay, there we go. That's something we're going to stay with it. So we'll start. So this is the committee that we had. Some very prominent epidemiologists on here. If you were interested in cognitive aging, Bob Wallace from the University of Iowa, Andrea LaCroix, who's now in San Diego, and Christian Yaffe, who is a very close colleague of mine and has been for many, many years, was the vice chair of the committee. I want to thank some individuals for slides, and I've got them listed here. We share slides freely in this process. Now, all IOM committees start out with a statement of task, and we have to stay within that task. So I think it's important to kind of understand what we're talking about when we talk about cognitive aging. We were charged with examining cognitive health and aging. We weren't using the term cognitive aging in the task to really look at what happens in terms of cognition in older persons before they reach the diagnosis of mild cognitive impairment, and certainly before they reach the diagnosis of Alzheimer's disease. Now, this is sort of tricky because there's no clear line that's in there, but we were asked to look at definitions and terminology, epidemiology and surveillance, and you can see some of the other areas that we're looking at. So I'm going to give you a perspective of what we recommended and what we found given this particular task. We did not wander beyond this particular task. So you know the demographics, a lot more older people than we used to have before. No need to stand on that very long. But let's talk a little bit about what cognition is. So cognition is not just memory. I think that's one of the key factors here. It's mental functions involved in attention, thinking, understanding, learning, remembering, solving problems, and making decisions, which means that probably no one simple task is going to be a good measure of cognitive aging. It can be a marker, it can be helpful, but there's no like one test or no marker specifically that's going to tell you everything you need to know about cognitive aging. Cognitive aging also is a gradual process. We don't know exactly when it starts. It probably maybe starts at the age of 25 to some extent, but in ways that almost could not be measured, and then probably picks up speed certainly around the age of 75 or 80. We'll talk more about that. It's a lifelong process. It's not a disease. That's an important thing to keep in mind, though it's something that we feel healthcare providers, epidemiologists, people interested in public health and policy need to pay attention to. And cognitive health, in this case, is exemplified by individuals who maintain optimal cognitive function with the process of aging. Now, cognitive aging is not Alzheimer's disease, and this is just some illustrations of how this varies. It's chronic neurodegenerative disease. It's Alzheimer's disease. Cognitive aging is just a normal part of aging. There's extensive neuron loss with Alzheimer's disease. You do not see that in cognitive aging. You see some loss of neuronal function. I'll get into that in a moment, but not loss itself. It affects probably 10% of the population. That's Alzheimer's disease. Cognitive aging is sort of everybody else that doesn't fall into that category. Declines in Alzheimer's disease are often severe and progressive. In other words, once you see the onset of the disorder, it can go pretty quickly. It can also go slowly, but it can go pretty quickly. And changes are variable and gradual with cognitive aging. There are a couple of things just about the definition itself that we struggled with on our committee, and I want to kind of go through those with you just briefly. Concepts change. So for example, everybody in our field of psychiatry, neurology, are familiar now with this concept of mild cognitive impairment. That was unknown probably 10 or 15 years ago. And so we've kind of added in a new category in trying to define what happens to individuals as they age in terms of their cognition. Again, cognition defined broadly. Because of this, we have to recognize that we must adapt our definitions based on what happens through time. But at the same time, if we're going to track an individual, we really have to use the same measures over time. So it becomes important to get the measures as best we can. And we've got to revisit the norms. So we may have measures but we may shift the norms as we go along. Whoops, now the thing is not responding again, which I'm not sure what to do about. Let's see if we can. Go ahead, do what you need to do.
Is the PowerPoint, did you drag it to the desktop?
No, but that's what I'm going to do now, yeah.
Okay, so we'll move on through here. Maybe the key factor in terms of definition is we did not use the term normal aging, we did not use the term successful aging. So normal often means there's a norm that everybody should be following. We realize there's too much variation to use that term. Successful aging, we didn't want to suggest that everybody who did not have Alzheimer's disease was actually aging successfully in terms of their cognition. So we stayed away from those terms. And we have to recognize that norms get reified, and those reifications often do not take into account things like education or social and occupational exposures. I suspect if you look at the people in this room and compare them to people who are in impoverished areas, you're just going to get different performance on the types of tests that we use, and we've got to keep that in mind as we go through our definitions. So, as I mentioned before, MCI is one of these conditions that is no longer with us. So just to give you a picture of this, and I think I've got a pointer here that I can use. This is what we might consider cognitive aging. This is sort of the progression from normal, sort of a declining cognition to the point that we are able to make a diagnosis of mild cognitive impairment, which is, again, no clear line, and then the progression from mild cognitive impairment to dementia, or what we now call major neurocognitive disorder. Again, no clear line here. The point I want to make is that when you look at sort of the preclinical area, at least up to here, you really can't tell the two apart. And so there's no clinical way that we really can distinguish the two. So when we talk about cognitive aging, we're talking about a process that's before mild cognitive impairment or dementia, but in terms of drawing an exact line, we really cannot do that either through clinical evaluations, through neuropsychological testing, etc. And just to give you an example of the numbers, this is by age, and what you see here are men and women, and the percentage who have either mild cognitive impairment or Alzheimer's disease or dementia, or one of the dementias, Alzheimer's disease being one of them, by far the most common. What you see is that any age, most of the individuals fall into this category that is not Alzheimer's disease or mild cognitive impairment, which means they are in that category that are subject to cognitive aging. Now, what are some of the key features of cognitive aging? And when I tell you these, this is sort of what we came up with based on an extensive look at the literature and a consensus view on what we felt, based on the literature, we could say about this new construct of cognitive aging. And I say new because I think we're the first that actually use this term as it's used currently. So what we mean by cognitive aging, it's inherent in humans and animals. So it just happens to everybody. It occurs across a spectrum of individuals as they age, regardless of where they start. So whether you're a PhD or whether you are a plumber, it doesn't make any difference. I sometimes think plumbers are smarter than PhDs. But nevertheless, wherever you start doesn't make a lot of difference if this is going to be something that's going to affect everyone. It's a highly dynamic process and variability, and I'll be showing you that in just a moment. It includes cognitive domains that may not change, may decline, or may actually improve. And so there may be domains such as wisdom, which we now have ways in part that we can measure, vocabulary, maybe certain types of reasoning abilities that don't change and may actually improve, while other areas such as memory, etc., will tend to decline, executive functioning being one of those. We're only now beginning to understand biologically what this is, and that's one of the real points we make here. Again, no neuron loss, but I'm going to show you there are some neuropathological changes. And it's not clinically defined neurologically or psychiatric disease such as Alzheimer's disease. So this is not a disease. Okay, so these are some functions that we're looking at, and it just gives you the fact you can see this decline taking place. Blue is episodic memory, and the orange is executive functioning. You can see they basically track one another. And when you take functions like this, it's pretty clear to see this change occurring, decline occurring with age. Here we have from age 30 up until about the age of 85, and you see it doesn't all of a sudden stop at the age of 65. It really is something that's occurring at a fairly gradual rate. You may wonder, well, why do we have professors who are 60 years of age and older? Well, it's that factor of wisdom, it's the factor of cumulative experience, etc., that allows them to continue to function compared to some of these functions here. Oops, and here we've got another. It's happened again.
Also, who's making the decisions about who stays as a professor?
That's right.
The older ones.
That's right.
I don't know, this happened in my classroom, this exact same thing.
I'm so sorry.
We ended up having to get them to come by, but I can't remember what the solution was.
You might be able to convert it to PDF form.
Difficult
If that's like
advance.
too much time.
Laura, if we called them, could they tell us what to do?
It might.
Does anybody have a
They
laptop?
actually came by the room last
Do you
time.
want to use a laptop?
Oh, we could use a laptop. Anna, do you have a
The PDF might actually just.
You just save as PDF.
Okay.
Like just change the.
Yeah, I think that might be faster because we tried the same thing a while ago.
So as they are doing that,
He has a PDF.
I'm going to
Brilliant.
let you work on it. I'm going to kind of go off my little cheat sheet here and go through some of the things. So one of the areas that we need to consider are these brain changes. And this is an area that really is new in trying to distinguish these two. So we just taking a look at cognitive functioning across a number of psychological factors and just tracing them over time, like I showed you in that slide just a minute ago, just probably doesn't really give you the picture that you need to see. What you need to realize is that they're actually brain changes that are typical of cognitive aging, and they're distinct from the changes that you see with Alzheimer's disease. And those changes are basically decrease in neuronal function, not loss of neurons. So in Alzheimer's disease, etc., you're seeing a change in loss of neurons. With cognitive aging, you're not seeing a loss of neurons, but the dendritic connections between the neurons are not as functional as they were at one time. It's a normal aging process. So let's see how we do with this going on from here.
Let's see if that works.
All right.
Otherwise, we can use
That's the
the advance on the keyboard.
All right, let's try
Yeah,
that. Let's try
yep,
that.
that'll work.
Okay, so another important factor is to realize those mean lines do not reflect everybody. This is a highly variable process. And so this is a look at a group of individuals. You can see the mean line and sort of the confidence intervals around that mean line. But if you look, each of those little dots connected is one individual. And you can see some are improving over periods of time, some are decreasing over periods of time. And so we have a tremendous amount of variability in this whole process. And so we have to be very careful that we don't assume that everybody is tracking the same course. I think in general, we see the decline, but we don't see it in everyone equally. See, I've got to do this. All right, so I think we've really covered this. Now, epidemiologists are always interested in case finding. And there are several problems with cognitive aging. And one problem is that it's time consuming. Another is it's just logistically not that feasible because you really need to do multiple cognitive tests. That's probably best done in a laboratory as opposed to doing it in an individual's home. and that becomes inconvenient. It needs to be longitudinal. As you know, following individuals longitudinally these days, unless you're fortunate like Dr. Heiss and with the ERIC study where they've got excellent participation, they've got people locked in who are really committed to a study. Just starting a study de novo these days is not an easy way to go. You've got to test individuals who are already impaired, and you've got to decide whether you continue to include them in your group or not. Are they already tracking toward Alzheimer's disease or mild cognitive impairment or not? And there's resistance to testing. Cognitive testing itself is stressful to older persons. We don't often think of it that way, but it's definitely stressful to older individuals. So psychological testing still is the mean in this. There's some other things that may be signals, however, of cognitive decline that we might use as proxies. And so in the best of all possible worlds, we might look at things like whether you can fill out your tax form, okay? Or can you download and use an app? And again, talking about older individuals, renewing your driver's license and tags online, preparing a meal from a recipe, going from Terminal 1 to Terminal 2 at O'Hare. That's not easy, okay? Serving on a committee for a volunteer social goal. All right, fixing minor appliance problems, adapting to challenges, personal and social situations, and preparing PowerPoint slides. Okay, so all of those might be, in their own way, markers of cognitive decline. And there are a number of other things too, where you can you may be able to track actual adaptations to that, such as